Hello everyone, happy evening. Am I audible and visible? Yes, is the audio visual all good? Yeah, thank you Pallavi for that nod. And yes, so we are all set to start the session. Apologies for the delay. I mean, many times at the last moment it is some technical glitch which generally it happens. We know that just before the exam day, while reaching to the exam hall venue, something or the else happens. So yeah, these are part and parcel of a life, right? So yeah, happy evening everyone, and welcome to our today's session. So we are starting with this new series which will be there every Tuesday 6 p.m. on Unacademy NEET PG YouTube channel, which is called C3 with N3, that is cheat codes and concepts to crack NEET PG with your mentor Dr. Nikita Nanwani Nathani. So that's C3 with N3, right? As I always say that the only two things needed to crack any exam, not only NEET PG, be it AIIMS, JIPMER, PGI, any exam, IIT, IIM, whatever, you just need concepts, and where there are no concepts, there are facts. You need cheat codes to remember those. So that is why all my sessions, they rely on cheat codes and concepts. So that is why we have this series. I am sure that all of you are aware that we have many free sessions going on Unacademy app as well, apart from the special courses for the plus subscribers as well. So this is the episode 1 of our series in C3 with N3. This is the episode 1. As I told you, every Tuesday 6 p.m. we would be having this. So next Tuesday and after that we would be having episode 2 and episode 3 on 18th and 25th of August. So I also hope that all of you know that we have started with the Operation NEET PG 2021 course on August 10th, that is yesterday, which will go on till December. So even if you have not started your preparation for NEET PG 2021 yet, or you are not very confident, this is the batch to join for. All the 19 subjects would be covered with MCQ practice. So it will definitely give you an extra edge. And the most important thing about Unacademy subscription is that once you subscribe to the platform, you can access not only this course, but all the classes of all the educators going on the platform. So basically, as I call it, it is the Netflix for preparation for NEET PG. So all the movies are going on. You have to decide which movie you want to watch. So you can use the code Dr. Nikita for additional discount. Apart from that, if we have students who are final year or pre-final year students here, we have also started with NEET PG 2022 or next 2022 batch from yesterday. So it's a 1-year batch. It will go on till June 2021. So in both these courses, I'll be catering to your radiology subject. So I hope all of you make the best of this. This is another series, Kaun Banega MD. We had season 1 last month and it was a huge success. So on students' request, we are coming up with season 2 this month as well. These are free classes on the Unacademy app. So like your KBC, you have Kaun Banega MD, 15 questions arranged in ascending order of difficulty in each episode. You have your episode 1 of season 2 tomorrow, that is 12th of August, 6 p.m. All the classes are at 6 p.m. my classes. The topic for tomorrow, please come prepared for the tomorrow's topic, that is amino acids. So you'll have 15 questions on the topic of amino acids. After that, 13th of August. So tomorrow you have KBMD. After that, day after tomorrow, 13th of August. As I had promised in one of the special classes where I had taken toxicology mnemonics, I'm starting with a dedicated toxicology mnemonics course because as you must have seen in the recent AIIMS, there were many questions on toxicology. So it becomes a bit difficult to remember everything about all the poisons. So we'll try and simplify it for you. So I'm starting with the toxicology course, mnemonics course on 13th of August. There would be 6 sessions of 1.5 hours each. So total 9 hours of session from 13th of August to 3rd of September. You can see the entire schedule on the website or the Unacademy app. Apart from that, you also have these free sessions of radiology spotters every Monday 6 p.m. on Unacademy app. Yesterday we were done with episode 1 of chest radiology. Episode 2 is neuroradiology. Some amazing images spotters coming your way next Monday, that is 17th of August on Unacademy app. Again, it's a free class. Also this month we are starting with the concise course on radiology for NEET PG 21. It is for the subscribers. It's a plus course. These would be weekend sessions on Saturday and Sunday, 4-hour session. So we will be seeing entire radiology, and trust me, I'll simplify the subject of radiology for you. I mean, it would become your favorite subject after that. So we'll start on 23rd of August. So it is weekend classes, Saturday, Sunday, 2 hours, 4-hour session. So if you're not yet subscribed, make sure you do this before we start the toxicology and the radiology courses, because these are very, very high yielding. All right. No, the amino acids is tomorrow in the KBMD episode. All right. Now let's start with our today's session. The cheat codes. Please start answering. Grade-Inigo syndrome is associated with which of the following? You have the options right in front of you. So this is your question from the subject of ENT. Grade-Inigo syndrome is associated with which of the following? So I can see many students getting the right answer. Some students have answered D as well. So yes, majority of you are right. It is option A, which is otorrhea, diplopia and pain in trigeminal distribution. Someone answered option D, that is deafness, vertigo and tinnitus. Can you tell me this triad is seen where? The triad of deafness, vertigo and tinnitus. Where do you see this triad? Absolutely right. It is seen in Meniere's disease. It is seen in Meniere's disease. So the cheat code to remember this is, that Meniere's, you get this triad. So I still remember I had made this mnemonic in my third minor when I was reading for ENT subject. So the mnemonic to remember for Meniere's is TVS. Okay, so you have TVS Scooty. So TVS, that is tinnitus, vertigo and sensory neural hearing loss. So that is TVS is your Meniere's disease. This is your Grade-Inigo syndrome. The mnemonic to remember Grade-Inigo syndrome is, the triad is ear. What does ear stand for? What does ear stand for? Yes. So you have ear discharge. A stands for abducent nerve palsy, that is your 6th cranial nerve palsy, and R stands for retroorbital pain. Retroorbital pain, that is pain in the trigeminal nerve distribution. All right. So please, make a list of all these mnemonics handy so that it becomes easy for you to revise at the end. So for ENT, remember these two. TVS is Meniere's, ear is Grade-Inigo. E stands for ear discharge, A stands for abducent nerve palsy, R stands for retroorbital pain. Now when you have abducent nerve palsy, which is the 6th nerve palsy, we know it supplies which extraocular muscle? It supplies the lateral rectus. So you have lateral rectus which is paralyzed. It leads to diplopia. Okay. So that is why the patient will have diplopia, one of the manifestations in the triad of Grade-Inigo. Second, we said in the ear. Third, we said it's retroorbital pain. We know pain in the face or retroorbital is due to trigeminal nerve, right? Such sensations are carried by the trigeminal nerve. So please remember, what is the triad? What is the mnemonic? The mnemonic is ear for Grade-Inigo syndrome. Ear discharge is very, very important. So generally for your, what is Grade-Inigo syndrome actually? What is Grade-Inigo syndrome? It is petrous apex inflammation, petrous apicitis. So you have the two petrous temporal bones. So you have the petrous apex. So if there's an inflammation in the petrous apex, that is called as Grade-Inigo syndrome. So remember that even after mastoidectomy, if the patient presents with persistent ear discharge, always think of Grade-Inigo syndrome. So in clinical features, if you get a patient presents with persistent ear discharge, even after mastoidectomy, always think of petrous apicitis. So this is where, as I say, anatomy, the visual memory is the best. So this is where you see the petrous bone. This is where you see the petrous bone. Can someone tell me what bone is this? We have seen in the recent session where we discussed the, what did we discuss? The paranasal sinuses radiology. What bone is this? What bone is this? This is the petrous bone. So what bone is this? Yes, very good, very good. Absolutely right. So you guys remember that it is clivus, right? It is clivus. So you can see posterior to the sphenoid sinus is the clivus. So you have petroclival suture here, petroclival joint. And this, what is shown in the yellow here? What is shown in the yellow here? So that is your course of the sixth nerve, abducent nerve. Can you tell me which canal is it through which the abducent nerve goes? The sixth nerve canal is which canal? Dorellos canal. It is the Dorellos canal, right? It is the Dorellos canal, right? So you can see that how this Dorellos canal, the sixth nerve is very close to the petrous apex, and that is why the sixth nerve is affected. Why have I given this image? For the visual memory. When you remember this image, petrous apex hai, uske baaju mein Dorellos canal hai, abducent nerve hai, so involved in petrous apicitis, that is Graydon-Negos syndrome. Also close to the petrous apex here, you can see a larger pathway here. Here you will have the pathway of, you can see this largest, thickest cranial nerve going here in close relation to the petrous. Which nerve is that? That is your trigeminal nerve. That is your trigeminal nerve which goes through the Meckel's cave, which goes through the Meckel's cave. So that is why in your petrous apicitis, that is Graydon-Negos syndrome, you have fifth nerve which is affected, you have sixth nerve which is affected, and it is the temporal bone. So you have the ear manifestations, that is the ear discharge. All right. So this is about your Graydon-Negos syndrome. Remember, ear. The mnemonic is ear. Coming to the next question, the extrinsic compression in dysphagia lusoria is usually caused by. The extrinsic compression in dysphagia lusoria is usually caused by. Very good, Sagar, Tanveer, Harshal, Anvesha, absolutely right. So that is aberrant right subclavian artery. It is not aberrant left subclavian artery. Please do not make a mistake in these two options. Yes, so we remember it when you keep saying ARSA, ARSA, ARSA causes dysphagia lusoria. ARSA stands for aberrant right subclavian artery. So it is ARSA, it is not ALSA, right? So it is ARSA which causes dysphagia lusoria. And yes, so how do we identify this dysphagia lusoria? How do we identify what is the radiological investigation of choice for dysphagia lusoria? This is a question which is asked frequently. What is the investigation of choice for dysphagia lusoria? Yes? What will be the investigation of choice? Dinanka Sharma says CT. Can you give me a better answer for that? A more specific answer than CT? Absolutely right. It is angiography. So it would be CT angiography. Why? Because dysphagia lusoria is aberrant right subclavian artery. So it's a vascular abnormality. And we have seen that for any vascular pathologies, aneurysm, dissection, thromboembolism, the investigation of choice is CT angiography. So if you know dysphagia lusoria is due to aberrant subclavian artery, then it is CT angiography, which is the investigation of choice. What will you see on CT angiography? What will you see on CT angiography? You will see the aberrant course of the right subclavian artery. And this right subclavian artery, let me show you the image first, the anatomical image. Again, visual memory, very important. So you can see that this is the arch of aorta. This is the arch of aorta. Instead of 3 vessels, you can see your 4 vessels, 1, 2, 3 and 4. The last vessel here arising is your aberrant right subclavian artery, which causes dysphagia lusoria. Okay, which causes dysphagia lusoria. So you can see that this aberrant right subclavian artery, how is it going? What is the relation to the esophagus? What is the relation of ARSA to esophagus? Is it anterior to esophagus? Is it posterior to esophagus? Very good, Manisha. It is posterior to esophagus. You can see it is going behind the trachea and esophagus. So it is arising from the left, but then going behind, it goes to the right side. It's the right subclavian artery. So it goes behind the esophagus. So it compresses the esophagus from behind, and that is how it is causing dysphagia, leucorrhea. All right. So you will see posterior indentation on the esophagus. You will see posterior indentation on the esophagus. So this is how you identify. This is the CT scan image. You can see the bones are white. This is your arch of aorta. This is the arch of aorta that you are seeing, and you can see this abnormal vessel arising from the arch of aorta, which is going posteriorly, which is going posterior to the trachea and the esophagus here. So it is going posterior to both. This is your aberrant right subclavian artery. Look how it is going very close anterior to the vertebra. That means it is going in the posterior mediastinum. All right. So this is the classical image of ARSA. You will see a vessel going posterior to trachea and esophagus. And this, what investigation is this? Anyone? What investigation is this? So you can see a contrast. You can see white contrast in the esophagus. So this becomes barium swallow, right? That is barium swallow. Absolutely right. This is barium swallow. Now in this barium swallow, I've put the arrow already there. You can see that this is the smooth wall of the esophagus, and here you see something compressing on the esophagus. So that is an indentation. Now if you get this image in the exam, how will you decide whether this is an anterior indentation or this is a posterior indentation? Anyone? How will you decide whether this is anterior or posterior indentation? Abhishek, this is not barium meal. Here you are seeing esophagus, so this is barium swallow. We swallow through the esophagus, so it is barium swallow, right? Absolutely right, Rishi, absolutely right. If you see very carefully, you can see the vertebra here. These are the vertebra here. This anteriorly is the shadow of the heart. So this becomes anterior heart, posterior vertebra. So you can see the indentation is posterior. So that is why most important diagnosis to be remembered is ARSA. It is ARSA. We have discussed many times what will cause anterior indentation on the esophagus. This was one of the recent NEET PG question. Which chamber enlargement? We have already seen this in our sessions in Plus course. Which chamber enlargement causes anterior indentation on the esophagus? You can see here, this is the heart, this is the heart. So which chamber enlargement will cause anterior indentation? Absolutely right. It is left atrium. All right. It is left atrium which causes the anterior indentation. It is the posterior most chamber of the heart. So it will cause anterior indentation. ARSA will cause posterior indentation. Clear with everyone? Right? Let's go to the next question. So let me see how many of you remember. We have discussed this in our free class last month. For those of you who missed this session, please watch that session, Toxicology Cheat Codes. And I'm also starting with a plus course for subscribers this Thursday on 13th of August, 6 p.m. So we will discuss entire toxicology. Make sure you do not miss this sessions. I'll tell you some amazing cheat codes to remember entire toxicology. Which seeds are this? Which seeds are these? So I can see mixed answers here. I can see A and C being confused here. I can see A and C being confused. Okay. So we had seen the cheat code to remember this is, if you see this seeds very carefully, you can see something like a pointed end, something like a pointed end, like the pencil end or like the nib of a pen. We had ink pen which had a nib, right? We used to write during our school days with the ink pen. So you have a nib of the pen. So similarly, can you see this like the nib of the pen or the, the sharpened pencil? So you can see like this is the end of the sharpened pencil. So we use pencil or pen to write. That means to mark something, right? We use pencil or pen to mark something. So this is the image of your marking nut. This is the image of marking nut. Now, which of these is a marking nut? Semicarpus. Look at the spelling. Semicarpus you can mark. Okay. Semicarpus is your marking nut. Okay. Semicarpus is your marking nut, which is also called as bhilava. Right? Yes. So mark is with pencil or pen. You will see this pointed ends on semicarpus. Abrus precatorius, many students are confusing this with Abrus. I don't have the image right now, but I hope you remember we had the cheat code. Abrus is like crab eye, right? It is crab eye. So please watch that session and attend the plus course. You will get to know all the cheat codes. How do we remember the various images of all the seeds, the snakes, the metallic poisons and everything. All right. Yes, crab eye. Absolutely right. Let's go to the next question. This was a question, a related question, not exactly this question. In one of the recent years, it was asked in one of the recent JIPMER exam. Xeroderma pigmentosa is a defect in. Very, very important and a frequently asked question. So basically you have DNA damage, repair, defects. Please read this topic. It is very important in biochemistry. DNA damage, repair, defects. Absolutely, you guys are amazing. It is nucleotide excision repair. It is nucleotide excision repair. The question asked in recent JIPMER was, which of the following is not correct about Xeroderma pigmentosa? One of the options was it is a base excision repair defect. You know that it's a nucleotide excision repair and not base excision repair. So that was the option. So please remember that Xeroderma pigmentosa is your nucleotide excision repair defect. Very, very important. Can you tell me a disease, DNA mismatch repair defect? Which is DNA mismatch repair defect? Yes, Nishu, I'm coming to that. Absolutely right. Which is the disease which is a defect in DNA mismatch repair? No, not ataxia telangiectasia. Very good, Karunya. No, it is not Bloom syndrome. Please remember, again, this is frequently asked. I remember reading it so many times while I was preparing for my exam. HNPCC, okay? Hereditary non-polyposis colonic cancer. HNPCC is your mismatch repair. HNPCC is your mismatch repair. Now, non-homologous end joining repair. Which is the disease in non-homologous end joining repair? It is SCID, severe combined immunodeficiency. Bloom syndrome and ataxia telangiectasia, they come in your homologous. That comes in your homologous. Alright. Homologous is Bloom syndrome and ataxia telangiectasia like syndromes which are autosomal recessive. Okay. Thank you, Farah. I'm so glad to see you here. We have one of the students who had attended my offline live class in Hyderabad. So, long time I have not taken offline classes because of the COVID. But good to see you here, Farah. Alright. So, now, please remember that DNA mismatch repair. So, when you have mismatch repair, MM is your double wala disease, double alphabet, HNPCC. So, MM is HNPCC. Xeroderma pigmentosa is nucleotide excision repair defect. Non-homologous is SCID. Bloom syndrome is homologous. It is autosomal recessive. Okay. Let's go to the next question. Heart failure is seen in which glycogen storage disorder? Heart failure is seen in which glycogen storage disorder? Very correct. It is Pompei's disease, right? This is Pompei's disease. It's very, very easy to remember this. What is the cheat code to remember this? So, Pompei's disease causes pump failure. What is the pump of the body? The pump of the body is the heart. So, remember that Pompei's disease causes pump failure. That means it causes, yes, heart failure. Other very important points about Pompei's disease to be remembered. What is the other MCQ which is asked on Pompei's disease? Very good, Jafar Khan. It is acid maltase deficiency. What is the other thing? It is an exception in the glycogen storage disorder. It is the only glycogen storage disorder. Very good. Very good, Manisha. Dinanga Sharma. It is a lysosomal storage disorder. It is a lysosomal storage disorder. Okay. So, the only glycogen storage disorder which is lysosomal storage disorder is your Pompei's disease. Why is it so? Why is it the only lysosomal storage disorder? Because the enzyme which is deficient in Pompey's disease. Now tell me first of all, lysosomes, right? What is the marker or the most important enzyme in lysosomes? Lysosomes, they have an acidic pH or a basic pH. Let us see that first. So it will be easy to remember. Lysosomes, acidic or basic? Yes, it is acidic, right? So you have acid, hydrolases and all of those enzymes important for lysosomes. So similarly, Pompey's disease is a lysosomal storage disorder. So the enzyme is also acidic, which is acid maltase, Easy to remember. So acid is lysosome, so it will be deficient in Pompey's disease, right? And what is the other name for acid maltase? We had seen in Kaun Banega MD session, where we had discussed the lysosomal storage disorders. There was one episode on lysosomal storage disorders. What is the other name for acid maltase? Anyone? Yes. Remember lysosomal storage disorders, we saw the similar enzymes, beta glucosidase, alpha glucosidase. Very good, Srilekha, Jafar Khan, absolutely right. It is alpha glucosidase. So remember, acid maltase or alpha glucosidase, A or A, it is lysosomes. Where did we see beta glucosidase? Beta glucosidase is Gaucher's disease. Where did we see beta galactosidase? Krabbe's, double B, right? We have seen the cheat codes. Where did we see alpha galactosidase? 1B wala disease, which is Fabry's. So Fabry's is 1B alpha galactosidase, Krabbe's is double B beta galactosidase, right? Yes. So lysosomal storage disorders, we have discussed all the cheat codes in the plus course also. Please watch that session. If you have not watched that session yet, it will clear all your doubts about lysosomal storage disorder. All right. Let's go to the next question. This is a two-step question. I mean an integrated question. A child presents with acrodermatitis enteropathica. The deficient mineral is a cofactor for which enzyme? So first you have to decide which is the deficient mineral, and then you have to decide what is it a cofactor for. So these kind of questions are asked now in NEET PG. Option batao, what is the answer? This is not a subjective exam, it is MCQs. Absolutely right, Dinanka Sharma, very good. So this is your zinc and the enzyme is carbonic anhydrase. So what is the cheat code to remember? First, acrodermatitis enteropathica, as the term says, what are the features in acrodermatitis enteropathica? It is enteropathica. Entero means intestine involved, so there would be diarrhea, right? That is diarrhea. The term itself is self-explanatory. And you have acrodermatitis, right? So acro means the limbs, palms and soles affected, perioral area also affected, and perianal lesions are skin. So you have skin lesions as well, right? So you have perioral lesions affecting the limbs, that is palms and soles. You have perianal lesions also. So dermatitis with diarrhea in a child, it is zinc. Okay, so remember, it is the deficiency of zinc. So the cheat code to remember here, that for zinc it is carbonic anhydrase. Remember that zinc and carbonic, they are rhyming. So you have carbonic and zinc, so they are rhyming. So this is very frequently asked, favorite question with examiners since ages. So remember, carbonic is zinc. These are rhyming, right? Can you tell me what is the cofactor for xanthine oxidase? What is the cofactor for xanthine oxidase? Xanthine oxidase is? Nahi, Manisha, it is not copper. Copper we already saw in the recent biochemistry cheat code session. It was a free session again, right? It is molybdenum. Right? MO, that is molybdenum. Do not confuse with magnesium, manganese, copper. It is molybdenum. What is the cheat code to remember? XO, xanthine oxidase, is MO. Okay, so XO is MO. Xanthine oxidase is molybdenum. XO is MO. Carbonic anhydrase is zinc. Tyrosinase के लिए what is the cofactor for tyrosinase? Tyrosinase is, yes, we have seen this. Very good. Copper. What is the cheat code that we saw for copper? What is the cheat code that we saw for copper? 2 days back we had biochemistry session. For students who missed that session, please watch that session. It's still available. It's a free session. All of you can watch. Absolutely right, Nishu. All your enzymes containing Y in their spelling, like tyrosinase, right? Tyrosinase, lysyl oxidase. What was the MCQ that we saw? Copper is in mitochondrial superoxide dismutase or cytosolic. It is in cytosolic, right? Again, Y, cytosolic, right? Cytosolic superoxide dismutase. We have already seen that. What is the cofactor for deiodinase? Anyone? What is the cofactor for deiodinase? Remember, for deiodinase, it is selenium. It is selenium for deiodinase. Okay. So again, this is very, very important. Cofactors and coenzymes for all the enzymes. This is asked very frequently. So before the exam, make sure you revise this topic. Okay. Next question. Hemolytic anemia is seen in deficiency of which vitamin? Hemolytic anemia is seen in deficiency of which vitamin? So the common mistake, I mean, in a hurry in the exam hall, the mistake that we can make here is we think that vitamin K is responsible for bleeding and all. So remember, hemolytic anemia in the newborn, in a child, is not vitamin K. It is vitamin E. Hemorrhagic disease of newborn is something which is vitamin K, not hemolytic anemia. So what is the cheat code to remember this? Okay. What is the cheat code to remember this? That vitamin E, absolutely right. It is E stands for erythrocytes. Okay. E for erythrocytes. So it is vitamin E which affects the RBCs and causes hemolytic anemia. Okay. So please remember vitamin E for erythrocytes. So it causes hemolytic anemia. What are the other features of what are the other features in vitamin E deficiency? One is your hemolytic anemia. What are the other important manifestations? Please remember, you have neuromuscular manifestations. It causes neuromuscular manifestations, like it can cause ataxia. It can cause retinopathy also. Okay, so it can cause ataxia, retinopathy. All these are very important manifestations of vitamin E deficiency. It can cause ataxia. Sagar, burning foot syndrome we saw where? Burning foot. Foot is pant. Pant is 5. So pantothenic acid or vitamin B5, right? Nahin. Glutathione reductase, Dinanka Sharma. Glutathione reductase is a marker for which enzyme? Glutathione reductase is a marker. We do the assay of, we see the levels of glutathione reductase for which enzyme? Which enzyme? Please remember, it is vitamin B2, riboflavin. It is riboflavin. It is not your vitamin E. Alright? Yes. So we have discussed the vitamins also in one of the sessions in Plus course. Please watch that session again. You know, the manifestations of all the vitamin deficiencies with all the cheat codes we have already discussed. Now coming to the next point here. Okay. Now, do you remember what is vitamin B6? Vitamin B6. Which enzyme is vitamin B6? Pyridoxine. Pyridoxine, right? Pyridoxine. How do we remember? You know, we get confused. B6 konsa, B5 konsa. 6 is pyridoxine. 6 is pyridoxine. One of the recent AIIMS exam question, important manifestation of B6 deficiency. Important manifestations of B6 deficiency. Yes, so pyridoxine first, it is vitamin B6. It is required for synthesis of which neurotransmitter? It is required for synthesis of GABA. Okay, it is required for synthesis of GABA. GABA is a inhibitory neurotransmitter. So therefore, if there is pyridoxine deficiency, GABA will be less. So inhibition will be less. So neurons overactivated. So that will lead to convulsions. That will lead to seizures or convulsions. So the question was, for neonatal seizures or convulsions, what treatment is given? Pyridoxine is important. Okay. So remember, it causes convulsions. Next, pyridoxine deficiency is seen with INH. It is seen with INH. Okay. Isoniazid used for treatment. So it causes peripheral neuropathy, INH affecting the pyridoxine levels. Next, it is used in treatment of morning sickness. It is used in treatment of morning sickness as well. Okay, it is used in treatment of morning sickness. Please remember all of these important questions on pyridoxine. Important questions of pyridoxine. Do you remember what was the test that we saw for folic acid in the biochemistry session? Which test, which biochemical test is done for folic acid deficiency? Yes. Very good, Viramani. For pyridoxine, also remember sideroblastic anemia. Absolutely right. Very good. F for F. It is FIGLU. It is FIGLU test. FIGLU is formed from which amino acid? FIGLU is formed from histidine, right? It is formed from histidine. Therefore, we also use the test which is histidine load test or FIGLU test. What is this FIGLU required for? This FIGLU combines with tetrahydrofolate. We have seen this tetrahydrofolate and forms your formamino tetrahydrofolate, right? So that is why if there is deficiency of folic acid, FIGLU will not combine with folate because there is no folate. So you will have increased levels of FIGLU in the urine. So increased excretion of FIGLU in the urine is there. All right. Please remember all of these. Can someone tell me why do we see sideroblastic anemia or sideroblast in pyridoxine deficiency? Why do we see sideroblast in pyridoxine deficiency? Yes? Why do we see sideroblast? Very, very important. Absolutely right. Absolutely right. Because pyridoxine is required for heme synthesis, for your enzyme ALA synthase, the rate limiting enzyme in heme synthesis. We have seen all of this again in the topic of porphyria. We had a plus course session and there's a session on YouTube also. So please revise that. Porphyria made actually easy. So it is required for heme synthesis. So if pyridoxine is not there, heme is not synthesized, so the iron is deposited. So that leads to sideroblast. That leads to sideroblast. Right. Absolutely right. Okay. So this was about it. Now coming to the next part, the last part for today's session, very, very important. I'll make this very easy for all of you. So this was the query asked on my Telegram group today by Abhay. Do we have Abhay here? And I promise that we'll discuss in the today's YouTube session, right? So the easiest cheat code, if they give you images to identify whether this is competitive, non-competitive or uncompetitive inhibition, they give you Lineweaver-Burke plot, which is also called as double reciprocal plot. Double reciprocal plot. Okay. So how to identify whether this is competitive, non-competitive and uncompetitive inhibition? Again, we have seen the normal graphs for competitive, non-competitive inhibition, right? So what happens in competitive inhibition? What changes? Do you all remember the cheat codes for that? Competitive versus non-competitive versus uncompetitive. Recently we had discussed. So competitive we write as competitive KOM. So in competitive KM changes. It is Km which changes. Absolutely right. Km increases and Vmax remains the same. Vmax remains the same. Opposite is in non-competitive. In non-competitive, Km remains the same and it is the Vmax which decreases. Okay, so this is opposite. What happens in uncompetitive, anyone? We had not discussed uncompetitive inhibition. What is uncompetitive? Now, uncompetitive inhibition means that it does not bind. So you have the enzyme, you have the substrate, and you have the uncompetitive inhibitor. This uncompetitive inhibitor does not bind to the enzyme alone. It binds to the enzyme substrate complex. Okay. So only once the substrate binds here, then only your uncompetitive inhibitor comes and binds. So uncompetitive inhibition means it binds to the enzyme substrate complex, unlike your competitive and non-competitive which binds to the enzyme. Okay. Yes, absolutely right. So in uncompetitive, both decrease. Your Vmax and Km, they both decrease. Okay, remember that both decrease. Km does not increase. Remember, both decreases. There is concept behind that, but I am not going into the details right now because of the time constraint. Okay. So we had seen the graph also. If this is the normal graph, that means without the inhibitor, if this is the graph, no inhibitor. Competitive inhibition, you can see the Vmax is same, right? The Vmax is same. So this is competitive inhibition. Non-competitive inhibition, you can see the graph comes down. That means the Vmax is decreasing. So this is non-competitive inhibition, right? Now coming to the main point that was asked, the query which was asked, which is how do we identify which are the Lineweaver-Burke plots for each of these? Okay. So कॉम्पिटिटिव इनहिबिशन में इतना याद रखो कि कॉम्पिटिटिव द ग्राफ विल बी क्रॉस्ड. Okay, so you are seeing that the blue one is the normal without inhibitor, right? The blue one is the normal without inhibitor. Okay, so the blue one is without inhibitor and the red one is with inhibitor. So you can see the two graphs, they are crossing, they are intersecting at one point on the y-axis. So competitive mein the two graphs, they will cross. What is the mnemonic for your non-competitive? In non-competitive, remember that, what will you remember for non-competitive? So when you write N is like V, okay? N is like V. So you have V there in non-competitive. You have ulta V also and you have Seedha V also. So this is ulta V, this is Seedha V. So in non-competitive, that is N, your two graphs would be, the two graphs would be V-shaped, right? It would be V-shaped. So you can see that they intersect on the x-axis. They intersect on the x-axis, okay? What is the cheat code to remember uncompetitive? Now when you write uncompetitive, that is U. So remember that U has two parallel lines. It has two parallel lines and then you join the two parallel lines. So you can see that you have the two parallel lines in uncompetitive inhibition. You have two parallel lines in uncompetitive inhibition. The concept is simple here. In your double reciprocal plot or the Burke plot, y-axis indicates the y-intercept indicates the 1 upon Vmax. Okay. So in competitive, the Vmax remains the same. So that is why you can see that the y-intercept remains the same. That is why the two graphs are crossing. In your non-competitive inhibition, Km remains the same. X-intercept is your minus 1 by Km. So you can remember as Km. So Km is the same, that is on the x-axis, right? That is on the x-axis. So there is concept behind it. I can tell you the concepts also, how this is derived, how there is the linear equation. You know, you have the linear equation, that is, you get this equation from Michaelis-Menten equation. Linear equation, y is equal to mx plus b. So in this equation, this is y, this is m or a. In the equation, we can call it a. This is x and this is b. So in the linear equation, if you remember some of the mathematics that we had learnt in 10th, 11th and 12th, b indicates the y-intercept. That is why the y-intercept is 1 upon Vmax. This is the y-intercept. This is x, right? This is x here, 1 upon s. If we derive it, again there's a formula for it. It is 1 minus 1 upon km. So x-intercept is minus 1 upon km. Y-intercept is 1 upon Vmax. Again, the cheat code to remember this. If they ask you in the Lineweaver-Burke plot, what does y-intercept indicate and what does x-intercept indicate? Both concepts mein nahi jao, just remember for the exam. Y basically indicates your V max. That means it is done ulta. It is the reciprocal plot. So 1 upon V max. X indicates minus 1 upon Km. So you have Km plus V max. So to remember, how do you remember this is when you say Y. Okay. So when you say Y. Okay, when we are pronouncing Y, you have V in it, right? You have V in it. So Y-intercept, Y is V max. X, okay? X is like cross. X is cross. Okay, so it is K. So X-intercept indicates the Km. Even if you remember one, that Y-intercept, Y is V. V max. So you know that X will be Km, right? X will be Km. So this is the way that you remember. I hope all of you will never forget this now. That if you see the crossed graphs, they are crossing at one point. It is crossed is competitive. Parallel is U, right? So it is uncompetitive. Non-competitive N is made up of two V's. So you have a V-shaped. So V-shaped means it is intersecting at the X line. It is intersecting at the X axis, right? So that means the X-intercept, X is the Km. So the Km is the same. That is non-competitive inhibition. All right. Let me just see this. Anvesha, thank you. I think all of you loved this cheat code. So we had a good end. Which slide do you want to see? DJ Rockstar, welcome to the league. I love mathematics too. Yes, Anvesha, any slide you want to see specifically? So please remember these graphs, and I think this will be very easy for you to remember now, like how to remember which is which inhibition. If you are a first year student, then you need to know the concept behind it. But for your MCQs exam, this is enough to identify the graphs. All right. So yes, that's all for today, guys. I hope you have enjoyed the session, and I hope you remember when do we have the next session. When do we have the next session? You have a free session tomorrow, 6 p.m. again, but on Unacademy app. 12th of August tomorrow, 6 p.m. Kaun Banega MD episode 1 of season 2. Topic is amino acids. So we will see some more biochemistry. I'll make biochemistry easy for you. 15 questions arranged from rank 50K to rank 1. Let's see who's getting to rank 1 of NEET PG tomorrow, right? And then day after tomorrow, I'm starting with the plus course, toxicology, dedicated mnemonics for the entire toxicology. You won't have to mug up toxicology at all after that. So make sure you attend this plus course as well. You can use the referral code Dr. Nikita for additional discount. It would be better if you attend the sessions from session 1 itself of toxicology, because the sessions would be in continuity. One cheat code will lead to second and the third, so they would be integrated. So it's better that we attend the sessions right from the beginning, and then you will have some more sessions, many sessions coming this month. Entire radiology as well, radiology spotters, which are free sessions. All right. Humaira, toxicology class, as I told, it's a course for subscribers starting on 13th of August, 6 p.m. All right. Dinanka Sharma, do not worry. I mean, I can totally understand you all feel that, we have already subscribed to other platforms. We are, going to other coachings. See this as an investment, which will give you big returns, right? So it's good to spend for the time being. I won't say spend, invest, because trust me, this will give you returns in the exam. It will definitely give you an extra edge in scoring more with whatever preparation you have done. I'll make sure that I add on to your preparation and you get, you study more in less time with all the cheat codes. Yes, so that's all for today, guys. I hope you have enjoyed the session. You will have next session on YouTube, C3 with Entry episode 2, next Tuesday, 6 p.m. Tomorrow, KBMD episode 1 of season 2. I'll see you with that. Till then, goodbye, take care, keep studying, keep revising, and keep winning. Goodbye.